So, good afternoon, everybody. I'm going to give you a second or two to slowly quiet down. And maybe one or two people might join in, so we'll leave the door open for a few minutes, but we are going to kick off. So first of all, a warm welcome to the University Medical Center Groningen for our external visitors. Really nice on this sunny day that you took the time to come over and hear some interesting stories about large language models in health. And I hope that you will enjoy the program, the discussion that we will have in the program, and also of course, the follow-up drinks. Yeah, and then my name is Bart Scheerder. I work at the Innovation Center and the Data Science Center in Health of the UMCG. And the Data Science Center in Health is actually the host for today. So that privilege gives it that I can do the opening, and I can tell you a little bit about Dash in a few minutes. And then after that, we will dive into the actual program. So that's the opening. Then we have Job Doornberg about tech for no more typing. It's an ambition that I think is quite appealing to many of our healthcare professionals. Then the keynote lecture from Jessica Workum about large language models in healthcare. She's going to deep dive into the technology and some applications and some ideas. So that's going to be really interesting. And then we have Marcel Alberti from HealthSage. He will elaborate on Node to Fire and the technology that they're developing within HealthSage and the applications that we can see there. And then Els Makelbergen will also touch upon the ethical, legal, and societal aspects of this technological innovation and the parties involved, etc. So that's going to be, I think, an interesting presentation that will spark the follow-up panel discussion that is going to be moderated by Job. And then I'll briefly wrap up. And after the wrap-up, I'm going to pre-announce this. After the wrap-up, I'm going to ask Job to guide the speakers to the personeelsrestaurant where the drinks will be. Because if we do not go there straight away, we will all stay here. And then we have drinks for a lot of people downstairs that are going to be underutilized, and we have some snacks. So that's why we're going to force you to move with us. And I think the speakers are a nice bait to follow. So that's why. So that's the program. Please enjoy. Then, first of all, a little promo film about Dash, the host for today. I hope this is going to work.
In today's healthcare, data science is not just a concept, but a game changer. From seemingly simple things like helping doctors take notes during patient visits, to advanced technologies like identifying rare diseases or predicting disease progression, it is revolutionizing patient care and transforming the way healthcare professionals work. UMCG's Data Science Center in Health, or DASH for short, is stepping into this data-driven future by harnessing innovation for the benefit of medical professionals, patients, and families. DASH provides comprehensive education in e-health and artificial intelligence within healthcare, in collaboration with the University of Groningen and various international partners. We develop specialized courses, minors and customized training for students, researchers, nurses and doctors to navigate the changing landscape of healthcare. Besides education, DASH actively supports pioneering projects by providing expertise, financial support, and IT support to make innovative ideas reality. We are building a thriving community of healthcare experts eager to collaborate, explore, and implement innovative solutions. Our goal is to ensure that students, professionals, and researchers are well equipped to understand and harness the power of data science in healthcare. Join our community and get in touch. Let's shape the future of healthcare together.
So who would not want to work there? Let's see if I can move it. Yeah, there we go. So I can repeat what was just presented in a very dynamic way, but I basically am going to do that really, really briefly. But at Dash, our vision is that we we want to be an international leader in the data-driven healthcare space. And in fact, we want to achieve that by bringing data science really into the DNA of our organization, because this technology is going to help us to build the future of health together. So that's the idea behind DASH. We've organized ourselves in this way. We have 4 key themes: machine learning, clinical applications of AI, e-health, and clinical cohort data. And then within those 4 themes, we have experts that are leading the way. Our activities and our facilities are briefly described here, but basically what we want to do through several different activities, we want to make sure that data science is really driven into the organization. And with these facilities that we offer, we feel that we can also support our organization to actually achieve those goals. So these are the DASH experts that are leading the way. We have Job Doornberg leading the way today as a DASH expert on clinical applications of AI, but we also have 4 others. And that's a cue to Job's presentation, I see. Yeah, so welcome again. Please enjoy, and Job, the floor is yours.
Thank you so much. Welcome to Groningen. As you would expect from an orthopedic surgeon, I will get very superficial in terms of the introduction for our keynote. So I will not go into depth in any way, but Jessica surely will. Any of you know this chameleon from the news? Recognize the chameleon from the news? Bart does. You do. Where's it from? Sora, right? Yeah. So by the guys of OpenAI, their Sora application generated this chameleon. So if you prompt this close-up shot of a chameleon showcases its striking color changing capabilities, the background is blurred, etc., you get this animation. Your prompt can be more extensive. So camera follows behind a white vintage SUV, dirt roads in the distance, trees on either side, clear blue sky, etc., and you get this. So if you're a good prompt engineer, you can be Steven Spielberg. That's the moral of the story, I think. We did not win the Eurovision Song Contest this year. Once again, we did not. But we did win, as the Dutch, the Holland, we did win the AI Song Contest. So the lyrics are made by the machine, then it's sung by men, and then the video is a co-creation of. How would you touch me? And how would you touch me? You can't give it up. How would you touch me? And never let me fall apart.
I was created to understand love, but could never feel it like a human does. My circuits across.
And if you're not impressed by AI by now, Belgian scientists published in Nature that AI makes our beers better. And despite all these achievements, Elon Musk still says that AI is one of the biggest threats to humanity. I completely disagree. I think we humans are still the biggest threat to humanity. And I think many of you, this is preaching for the believers, many of you believe that AI can make a difference in healthcare. AI is a tool and it will amplify our creativity. And after Winston Churchill, we shape our tools and thereafter our tools will shape us. Please write the inaugural lecture of Professor Job Doornberg on the clinical applications of AI.
Dames en heren, ik ben vereerd om vandaag hier te staan om mijn inaugurele reden te houden over de klinische toepassingen van kunstmatige intelligentie in de orthopedie en traumachirurgie. In de afgelopen jaren heeft ontwikkeling van kunstmatige intelligentie en machine learning een enorme impact gehad op de medische wereld. In de orthopedie en traumachirurgie kunnen we bijvoorbeeld gebruik maken van kunstmatige intelligentie om precieze diagnoses te stellen, chirurgisch plannen te ontwikkelen en postoperatieve uitkomsten te voorspellen. Een voorbeeld van de toepassing van kunstmatige intelligentie in de orthopedie is de ontwikkeling van systemen voor het automatisch analyseren van röntgenbeelden, wat kan helpen.
So the point is that if the computer does the simple stuff, we have more time for our patient. And this is ChatGPT 3 point something. So it's old school already. Now you can do, if you're
非
invited
常
to
感
China,
谢今天有机会在香
you can
港
bring
中
your
文
own
大学
avatar.
介绍人工智能在顾客和外科手术中的临床应用，我非常感谢这个机。
So from a clinical perspective, I think the message is stupid simple. We need to take the computer out of the equation. We need to stop that. The computer should stop obstructing us from our patient care and should finally support us. That's the simple goal. So this is morning rounds in Groningen. Behind the curtain is a 17-year-old kid. He had a pelvic ring injury after high energy trauma. And you can appreciate that nobody's even looking at the kid. So our resident is completely preoccupied with the computer. Our nurse is struggling with orders. And I took a step back to take this picture. And this is not the care we want to deliver. Hopefully this soon will all be over and will be history.
Okay, Ortho, come on in. What up, CE bro? Have a seat. It has been brought to my attention that some doctors in this organization have been using artificial intelligence to write their progress notes for them. Oh, that's weird. Ortho, have you been writing your own notes? Oh, yeah, bro, of course. Oh, really? Post-op day 1. The patient describes her leg pain as a constant throbbing ache akin to a pounding drum beat. I've been practicing my metaphors, bro. Later on in your assessment, you use a semicolon. I love grammar. Complete sentences, no acronyms, no emojis. Does that sound like an ortho note to you? Nah, bro. What does it sound like? An infectious disease consult note.
So we're taking the first steps in that direction. Jessica will go into depth, but the simple first application was that a patient can ask a question. Can I weight bear after an ankle fracture, for example? Then ChatGPT generates an answer in Epic, and we can either change the answer or send it back right away. And our first results show that about 70% of these messages are sent back without any change from our side. So that would save some time. That's the idea. The next application was, for example, if you prepare your outpatient summary, so if you prepare your outpatient list for the next day, you can ask again ChatGPT in Epic to generate a summary. We have many multi-morbid patients and you have to go through lots of charts, and within 7 seconds you will have a AI generated summary. Anna and Terenom, who are here today, they are part of the PhD team Nooit meer tikken, and we looked at the completeness and correctness and conciseness of these summaries, and what we found is that they are in general, and the preprint, it's not accepted yet, but the preprint was in the top 10 downloads. So it gained a lot of traction, and I think it is a worthwhile tool in clinical practice, and it will save time, hopefully. But of course, this is the ultimate goal, that you truly never have to type again. So you see the patient in your outpatient clinic, the patient mentions diabetes, for example, that goes directly into medical history. Metformin goes into meds, and while you're talking, the computer makes sure that it's scripted and also categorized. So that's the whole goal. I think I'll leave it at that for now. Thank you so much. I'm looking forward to your keynote, Jessica, to go into depth of this superficial introduction. Thank you so much.
I can't really stand behind something like that because it just makes me feel like I'm having an exam or something. I want to talk to you a bit about generative AI in healthcare, what it is, what it potentially could do. But first, let me start with a song, if it works.
Groningen and Tilburg join hands using AI to meet demands. Research and innovation, they both share, improving healthcare everywhere.
Yeah, that wasn't me. That was generated with AI. I did this last night. I did the image, and I did the song, and it took me in total about 10 minutes to do so. That was fully generated by AI. The text was generated with ChatGPT, but the music and the vocals and everything was AI. It's udio.com, by the way, if you're interested. So a bit about me. This is me. Well, this is me if you ask Midjourney to create me as a Pixar. I have no idea whether there's a big giant zit on my nose. If it's there in real life, please let me know. And I work as an intensivist, a critical care specialist in what we call ETZ, which is a hospital in Tilburg. But I also work there as an AI specialist because I have a background in biomedical engineering. And I do research on AI, specifically large language models, at Erasmus MC and also together with Groningen. Why? Why do we need AI? AI is a tool, but let's start with a problem. This is the problem, right? We need to do more with less. We have an increased demand for healthcare. We have patients who get older, who have more comorbidities, and therefore need more care, need longer care. But we also have less healthcare providers. We have less nurses, and in a couple of years, I don't think anyone will ever work in health. No, I'm kidding. There will be a huge care gap. We cannot provide the care that we give now or that we need in the future. So the question is, can AI help bridge that gap? And Job has already spoken a bit about one of the issues, and that is that we as clinicians, doctors, nurses, etc., we have a high administrative load. This is a study in the US, but a similar study has been done in the Netherlands, where in this case it was 25% of the time a physician has in the clinic is spent on administrative tasks, such as creating notes, creating discharge letters, etc. And then the Dutch study was even more. It was 38%. It's in the NTVG, by the way. So these physicians not only spend a lot of time on administrative tasks, so not on direct patient care, but the interesting part is that they also expressed less career satisfaction and higher levels of burnout. But more importantly, well, not more importantly, maybe just as important, is that they also said it compromises their ability to deliver high quality care. In other words, that computer that's in front of them is obstructing them from providing the care that they want and they need. But fortunately, there is a new form of AI, which I call the Swiss Army knife of AI, which is generative AI. Generative AI, when I talk about generative AI in this talk, I typically talk about large language models, but you've seen some examples of generative AI in other forms, right? You've seen audio, you've seen images. That's also generative AI. But in healthcare, these large language models are interesting. And why is that? Because it's one tool that can do a lot of things. It is one tool that can read, that can write. You can reason with it. It can summarize, more on that later. You can brainstorm with it. But also it can translate. It can translate from language to language, but it can also translate from a high level to a lower level, B1 taalniveau, or from medical jargon to layman terms. And it can also translate to code, so from human language to computer language. And I don't know if there are any healthcare providers here, specifically nurses, but that means that you don't have to fill out lists anymore if it can translate normal text into code. And there's also some data analysis and visualization there. So what we did, ETZ and UMCG, is we implemented generative AI, and Job spoke about ChatGPT, bad Job, because it's the GPT-4 model, and I'll explain the difference later. We implemented that in our EHR in Epic, together with Epic, obviously, as the first hospitals outside the United States. And that's pretty cool. Generative AI, or specifically AI in healthcare, is booming. What you see here is that the growth of investments each year increases with 30%, so that now the total investment in the US market for AI is around $8 to $9 billion, but that increases to like $50 billion in just a couple of years. And this is global, specifically for generative AI, and you see a similar trend. There are huge investments in AI in healthcare. So it is booming and it is coming to your hospital. But why is it so appealing for healthcare? Why is generative AI so appealing for healthcare? Let me give you an example. And maybe some physicians or clinicians that do outpatient visits will recognize a similar type.
I'm here because of a cough. You know, doctor, a very irritating, tickly cough. At first, I thought it was my new cat, Luna, because it started when I got her 3 months ago. She's so cute. I should show you a picture. The coughing.
I won't let it ramble on, but you can imagine that there's a patient and you only have 10 minutes in your consultation for that patient, and you want to talk to that patient about her complaints, which is a cough. And you are talking to that patient, but she's also talking about her cat, and she wants to show her pictures of her cat. And you don't want to interrupt your patient because that's rude, but you have 10 minutes to finish this consultation. So what if, and you've already spoke a bit about this, this is just a lot of text, but in that text is a lot of information. And now a large language model, generative AI, can help us extract that information. Let me give you an example. This is her, by the way. This is her and her cat Luna at the Efteling. This is also generated by AI. By the way, when I do this in Dutch, I have a Dutch voice, which is, let's cut this out of the recording, which is Princess Beatrix, but I couldn't do her in English. So if you give this text to the large language model, you prompt it. You give it an instruction to do something with that text. And in this case, I'm asking it to extract specific information. And it does that. It does that in seconds. It extracts the age, the sex, the complaints, but it also does something, it doesn't do something. What you see here is it says the clinical frailty score. I can't do that because I don't know what it is. And for you, the clinical frailty score is something we use in the ICU a lot, and geriatrics uses a lot. It's a scoring list from 1 to 9, what the pre-existing level of fitness of that patient is. So it says, I don't know what the clinical frailty score means, so I can't say that. Well, in that case, I'll just give it the clinical frailty score. This is ChatGPT, by the way, so this is fake data, obviously. I prompt the language model with the clinical frailty score. And in seconds, it gives you the clinical frailty score, and it also tells you why, in this case, this patient has a clinical frailty score of 4. And it does that in seconds as well. But I spoke to you before about that a large language model can also translate from human language to computer language. So I asked the model, put it in a Python dictionary. Python is a programming language. And it does that too. It does that in seconds. So this means if you can translate something from human language to computer language, that you don't have to fill out lists anymore, because the computer can do that for you. Like I said, there is a lot of information in that text, right? In this case, there's weight information about this patient. She told you about, while she was talking about her cat, she also told you a bit about her weight. And with one sentence, I can ask that language model to plot that weight over time, plot the course of the weight loss, and the x-axis should be time in months. It does that in seconds. It doesn't require me to import it into somewhere else or to program something. But there's more. What if we add physician information? So we have the text of the patient, and we say that the physician says that this patient is considered for COPD or lung cancer, and he recommends a treatment such as a X-ray and a pulmonary function test, etc. I just say okay, so I put that into the language model. And I asked to generate a discharge letter or a letter for their general physician, for their Huisarts. And in this case, it's a very simple prompt. I just want the history and examination, the conclusion, and the treatment plan. And it does that too. It does that in seconds. So I don't have to type that anymore. But I can also, excuse me about this, but I can also translate this into layman's terms. So give the patient the letter in terminology that she would understand. In this case, it explains what the X-ray is. It's a simple and quick picture of your lungs. But it also does this. It also says, I know that you're dealing with health issues and that can be worrying, and I want to reassure you that you're not alone in this, and we're here to support you through every step. I am not that nice to my patients, but maybe I should be, right? So my point is this. You all saw this happen with just one piece of text, a transcription and doctor information. And that is why I think that generative AI will finally make sure that the computer adapts to the human instead of that the human has to adapt to the computer. And which is, if you're a healthcare provider and you're using an EHR and that thing is in front of you, and we've all struggled with the computer, with getting it, getting our way of thinking in the computer as the computer wants it to be. I'm talking about a computer as if it's a human, right? So I think that because of this technology, generative AI can immediately help reduce that administrative load. But how does it work? Because I think it's important that when we start using these tools, we broadly know a bit about how this technology works. There's a difference between the traditional forms of AI and the new form generative AI, which isn't that new anyway, but discriminative AI is what we traditionally call the prediction models or the classifier models, right? If I have a model that predicts if a patient will deteriorate in the general ward to be admitted into the ICU, that is a predictive model, and that is discriminative AI or traditional AI. But a generative AI model can create new content. And you've seen a couple of examples. You've seen a large language model. You've seen image models, etc. So this is how a large language model works. What if I train a model just on this sentence, not the entire internet, just on this sentence? What happens is that in that sentence, there's structure. Some words are repeated, such as was in this case. And an if is also repeated. And then if I ask that language model, which is just trained on this sentence, to form an output, what it does is it just predicts the next word. What are the odds that if I have the sentence, early one morning the sun was, well, the chances that the next word is laying, in this case, is 33%. That's it. That is what a large language model does. It predicts the next word. And yes, there are very, very, very many nuances to this, but this is what you need to remember. So if you have a large language model that is not trained on just that sentence, but, for example, the entire internet, then you have a lot of language. And obviously, there's information in there. And then if you prompt the model to predict the next word, then if you have the sentence, the cat sat on, then the most likely next word is the, but it can also be a or it. That's it. Some terminology to keep in mind. A large language model, an LLM, is the technology that makes this possible. It is generative AI with language. But there are many, 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 many models out there, right? The GPT model is one of them, but you also have Bard, you have Llama, you have Claude. I don't know if you guys have already tried Claude 3.5 Sonnet. It is amazing, but the GPT model is the most known model, and that is just one model of the models that are out there. It is a model created by OpenAI, which is a company. And I say so far this is the model with the best performance, but I think that maybe in 1 or 2 weeks I have to change this into Claude 3.5 Sonnet, but bear with me here. And ChatGPT, that is an application of the GPT model. ChatGPT is when you go to chatgpt.com, which a couple of weeks ago was chat.openai.com. You can use the underlying model, GPT 3.5, GPT 4, GPT 4.0, and play with these large language models. But ChatGPT and the GPT model are not exactly the same, and I will explain a bit later on what these differences are. So what is a large language model? Please remember this. It is a language model. It is not a search engine, okay? It is just a lot of language that is combined together. But obviously, it's huge, so there is a lot of information in it. And if you know that a large language model, all it does is predict the odds of the next word, then you can also imagine that it can generate a lot of bull, right? Because it just generates the next word. So we call that hallucinations, right? Something that an output of a large language model that is incorrect, but it looks like it's correct because it says so with a lot of confidence. I don't like the word hallucination. I prefer the word confabulation. Okay, but what is a large language model good at? It is good at analyzing language. It can summarize, it can make connections, it can write text, extract text elements, all the examples you saw before. So why is that big pile of blocks there? Because if you see that large language model as a big pile of blocks, and you want to extract information from that big pile of blocks, for example, I want the blue blocks, right? I want information, specific information. You can do that with prompt engineering, with writing sound instructions to the models. Instruction to the model is called a prompt. And the technique of doing that and doing that in the right way is called prompt engineering. And I'm not going to give you a lesson on prompt engineering, but if you are interested, I have written a piece for healthcare providers about it, and you can get it there for free. And I'll email it. It's fine. All right. So generative AI, I think it's disruptive technology. I think it will inevitably, I should say, come to your hospital. So I think you all should prepare for it. So what did we do? What did we do as A to Z and UMCG? I'm going to show you a couple of the use cases that we did. And this is the first. This is the in-basket functionality. This is a fake patient, by the way. And I left the slides in Dutch for a reason, because I want you to see that this works in a language that's spoken by less than 0.5% of the world population, right? And there's less than 0.34% of the Dutch language in the GPT model. This information is the GPT 3.5 model. I have no idea what it is for the GPT-4 model, but I'm assuming it's similar. So this is one of the functionalities. You have a patient that sends a message to their healthcare provider. And this is what we call in A to Z, mijn A to Z. It's called my chart for Epic. I don't know, what's it in Groningen? Mijn UMCG, there you go. So in this case, the patient sends a message. Last month, I was allergic to something. I had swollen lips. Do you remember what I was allergic to, and what's it called again, what that allergic reaction is? And there is allergy information in the patient chart. In this case, the allergy information is an allergy for strawberries, and the patient gets angioedema, which is a very severe reaction. So what you see happening, and I will zoom in a second, is that when you as a healthcare provider go to your chart or to the patient chart, you get the messages in there. But now there is also this, a generated draft answer. And it says, dear Mandy, thank you for your message. You said that you had swollen lips due to an allergic reaction last month. You're allergic to strawberries, and this can lead to angioedema. You had a good reaction to adrenaline and got an EpiPen. If you have questions, please make an appointment. And then you see two buttons. Either it's start with this draft, or it's a start with an empty answer. There is no send immediately button because we want the healthcare provider to make sure that they have read this message. And you also see a feedback button. So that is the first functionality. This is the second one, and this one is pretty cool. This is well, the other one is also pretty cool, but the next couple are pretty cool. This is the summaries functionality. And what you see, we were first in the world, not just outside of the US, but first in the world to implement this. That was also pretty cool because Epic was really proud of us. You know, we want to make Epic happy. No, I'm kidding. So the summaries functionality is what Job talked about, is when you prepare for an outpatient visit, You probably haven't seen your patient in 6 months or maybe a year, and there are a lot of notes and information in the meantime that you have to read in order to prepare for that patient visit. What you now can do is you can select these notes, and then you can generate a summary. And in this case, you see that there is a summary, but you see a couple of things more. You see that there are clickable links, so it is linked to the source. You as a healthcare provider can check, if you want, if the information is correct or not. Maybe you guys have seen this on LinkedIn. Kom naar Groningen. We all are here, great. Because UMCG has evaluated if these summaries created by this large language model are comparable to those of physicians. And yes, they're just as correct and complete and 28 times faster. Let me walk you through about how that scientific evaluation went. So there were 42 patient files selected, and for each of those 42 files, the physicians wrote summaries, and the LLM wrote summaries as well. They timed that, so we timed if how long the large language model took to generate a summary, and also the clinician was asked, if you write a summary, just time when you start and time when you stop. That was given, in total 400 summaries were given to 10 independent physicians and asked to compare in 3 domains. In the study, the preprint, you will see that there is a lot more to this, but this is, I think, the most vital information. So completeness, is there information missing? Correctness, is there false information, so those hallucinations that I talked about? And conciseness, is the summary brief enough? And also, we asked if you were to trust this summary to use in clinical practice or not, and if you recognized if it was generated by AI or a human. And these are the results. So for the timing, the clinician, on average, took 7 minutes to generate, or to write, I should say, a summary. The large language model did that in not even 16 seconds, and this will be a lot faster in the future. What's also interesting is that the clinician recognized in 90% of cases that a summary was created by AI, which is interesting because you hear a lot that we're not good at that anymore, but apparently clinicians are really good at that. And also, this is also interesting, of the AI summaries, 80% of the clinicians said they would trust it enough to use in clinical practice. For the clinicians, that was 70%, okay? Obviously, that's not statistically significant, but it was interesting nonetheless. Now for this one, for the completeness, correctness, and conciseness, these are the results. You see that the completeness and the correctness, this was a non-inferiority trial, by the way. So I can never say to you that the language model is better, but I can only say to you that the large language model was just as good as the clinician with regard to completeness and correctness. But you can see that large language model with completeness tends to be a bit better, but obviously I can't say that. You see that conciseness, that the physician wins, and that was statistically significant. But there's a catch there. Because we asked the large language model to write a summary of around 100 words, and on average the clinician took 60 words. That translates into like a 10-second reading time, that's nothing. But that is the statistically significant difference. So we conclude that the LLM summaries are just as correct and just as complete as physicians. And yeah, we're just getting started because the next functionality is on its way already. And I want to show you an example of an actual patient of the clinical summaries. So this one is also really interesting for nurses in the hospital. Please don't take pictures of this. What you see is on the right, this is a patient chart. You see on the right, generate a summary of recent actions and what you can do. And we still need to tweak everything behind this, but I just want to show you that we're making real good progress with this, is you can select which elements of the chart you want it to take into account. So you can take into account notes, but also lab results, etc. You have a look back period, 12 hours, 24 hours, 48 hours, etc. You have some other tweaking, like how long do you want this summary to be? And then you see that you get a summary of what they call the recent actions. And I think we need to talk with the project teams of A to Z and UMCG, what do we want to see, right? So we haven't done that yet. But you see that there is a summary there as well. And you can, just with the other summaries, you can check if that information is correct if you don't trust it. So there's always a link to the source. But there's more. You don't have to read all this. You see that there is a summary in bullet points. There's a less important summary of less clinically relevant points. And there are also all the references below that. So this is what we're currently rolling out to test. But the other ones are live in production. So I do want to give a little shout out to the teams of A to Z and UMCG and also EPIC, because this was a really great collaboration and still is an ongoing collaboration between the two hospitals and our EHR provider. Some considerations, because I've only shown you the cool stuff, but there is a lot of stuff in the background that's going on, a lot of questions, and I would like to start with a crash course in Dutch and European law. Grab your pens, everyone. So obviously, what we're doing, we have to make sure that we do that in a responsible way. And one is that we are bound by certain laws. Specifically in the Netherlands, we have the VGBO, right? That is the law that addresses patient-doctor confidentiality. And if you have a large language model that retrains with information, by which I mean that the information that you put in goes into the model itself so someone else can, fish that out, then that is a breach. So you shouldn't do that. You should only use a large language model that is confined, that does not retrain, and that other people cannot use. Well, they can use a different instance of the model with a different API, but not that same. They can use the same model, but you have to make sure that the information that you give the model is not retained or that the model does not retrain with it. And the same goes for the GDPR, in Dutch AVG, right? If you use identifying personal data, you have to be compliant with the GDPR, and those laws are therefore similar. You can't use a model that retrains or retains the information. Another very important law is the MDR, the Medical Device Regulation. That is a European law that applies to companies, not to individuals. But that states that if you use, in this case, a large language model for diagnostics or for treatment suggestions, that is clinical decision support. And if you use it as clinical decision support, it is considered a medical device. And if it's considered a medical device, it falls under the MDR. And will take you about 2 years to get through that and a lot of money. So my point is this. We should not be using a large language model as a medical device. What we do is we restructure available information, and we've proven with the study that it doesn't add information, right? We are just restructuring or reframing already available information from the chart. We are not using it to suggest treatments or to think of a differential diagnosis, for example. And then there's the AI Act. Yeah, then I'll be here tomorrow. We can talk about this if you want during the bowl later on. But I'm confident that we will address all the issues, both as hospitals, as EPIC, and the underlying models. So what happens in the background? Because we need to make sure that we do this safely. We have the patient file, and there's selected relevant information from that patient file. For example, the allergy information that you saw. That, together with a prompt, so specific instructions to the model created by a team of prompt engineers, which in this case are medical experts and technical experts, that is the entire prompt, and that goes to the model, in this case the GPT-4 model created by OpenAI. It's not on the OpenAI servers, it's on the Microsoft servers. And that generates a response, and that response comes back into the patient file. There are important considerations in this case. One, this is unformatted text. So importantly, The model does not have free access to the patient file or anything. We just send flat text, and flat text comes back. And also, this all stays within the hospital cloud environment. So within the digital infrastructure of the hospital, it is not going to OpenAI or anything. They cannot access the information. So this is all safe. And then this is way too much to go through now, but my point is this. We are doing this as UMCG ETZ. We are doing this in a structured way where we make sure that we follow all these steps to do it in a safe and effective way. I will send that to you once it's published. So another couple of considerations, and then I will be wrapping up, is now that we have a model, we have a tool, will the clinicians use this, right? Will the nurses, if they can create a summary, will they use it? Because you can have the best tool that you want, but if people don't use it, then it's worthless. I compare it to, I'm also a clinical pharmacologist. If my patient does not take its medication, then I can have the best pill, but it will not be effective. And the same goes for this. You can have the best AI tool out there, but if people don't use it, then it's not effective. And usually when people don't use an AI tool, it's because of lack of trust, because of these considerations such as privacy, transparency, bias, etc. So what we do in our hospital in order to increase trust and increase adoption, we have an educational program where we train everyone, and when I say everyone, I mean everyone, not just healthcare providers, in the basics of AI with an e-learning, if they want. We also have a 2-day course for people in key positions in our organization, such as the medical managers, who can be, confronted with an employee who wants to do something with AI, and they need to think about if that could be of value to them or not. And then we also have a couple of more in-depth programs for people that excel and want to take this to the next level. We've just started our program AI. And our program AI, but what I mean by that is a lot of hospitals have AI initiatives, but they are not coordinated. They're because the orthopedics department wanted to do something and radiology wanted to do something. That's all good, and we want to encourage people to keep exploring, but we do have to think about how we embed AI in our organization in a responsible way. So we started a program of AI, of which I'm a part of, and we have one slogan, and that is the responsible and effective application of AI, anticipating the future. And responsible is the first word, and that is deliberately, because it's safety first. Patient safety first, healthcare provider safety first. Effective means that what we do with AI at ETZ, it should contribute to the goals of our organization. So it could improve in patient care, but also in reducing that administrative load, or making work a lot more pleasurable, etc. Application means that we focus on the implementation on AI, not developing models ourselves. We are a non-academic hospital. We don't have the resources to develop AI models. We want to implement them and bring them to the bedside. But there should also be room for explorations of novel applications, because we haven't proven yet that generative AI is beneficial to our hospital or to patient care, but you can make a real good case that it could be. So we need room for exploration. What will the future hold? And these are my last couple of slides. And Job has already touched upon this. I'm an ICU physician. When I do my rounds, I imagine this. There's a huge speaker there. It's obviously just a generic speaker, not Siri or Google or whatever. And that is listening to us. And my nurse is telling me about the status of the patient. And the resident physician and I are talking a bit about what that patient could have. And sometimes patients can talk themselves as well in my ICU. In the background, that audio is recording, and then a structured note is created. But there's not just the creation of a structured note. I also said to my nurse, I think we should draw sodium levels at 12 o'clock. Well, you bet your bottom dollar that I probably would have forgotten that I mentioned that a couple of minutes ago. But now there's a structured note, and all the orders that we discussed are ready for me to review. So not only do I think it will save me time, I think it will actually improve the care that we provide. That is the near future. If you go one step further, then this will be my ultimate future. If you use the LLM as that Swiss Army knife, as the reader and the writer, and you combine that with medical domain knowledge, with the entire body of scientific information, PubMed, guidelines, local protocols, etc. And you also combine that with that individual patient chart. That's the patient that's right in front of you. Well, then you can actually ask that model, what is the best treatment for my patient? And this is something that we can technically do. We can't do legally yet. But I do think that I will see this happening in my career. So my premise is this. I think generative AI will make healthcare, therefore, more human again. Thank you.
Yeah, thank you, Jessica, for a great presentation and really illuminating. Thanks. Any questions from the audience for Jessica? There we have one.
Hi, it's a really quick question, but I was wondering, in the back end of the of Epic, you should have prompt engineered like quite a lot of stuff. Is it a really long prompt? Because when I'm using GPT or another large language model on the internet freely, you are restricted by how many entities you can use.
Yeah.
So I made like a couple of parallel GPTs to get my results. What about the
Right. So this is a very good question. So there is short translation. There's a limit to how many words you can use with a large language model, and this is a good thing that we're friends with Epic and that Epic is friends with Microsoft. All right, because what we do is you are limited with ChatGPT. You are limited. When you use the API, you're limited less. But Epic makes sure that the tokens, they have a set amount of tokens that they are distributed through the hospital. So we are less bound by the token limit. Well, if you summarize clinical notes, for example, so the second example I gave, yeah, those are all going into the language model. That's a lot. So then sometimes we do hit the token limit. What you also should know, but this is maybe goes a bit too far for now, is there's a lot of redundant information in those notes, right? So our hospital tends to copy and paste the medical history into notes. And if that goes into the model every time, then it's redundant information, and also the model might think it's more important than it is. So what Epic is doing, not now, but what they will be doing, is they will find a way to extract the relevant information, or actually I should say to remove the redundant information. Then the notes are shorter. That can go into the list of these are the notes to summarize, and that goes into the model. So there are ways to work around that token limit. Right.
And maybe introduce yourself briefly as well. Thanks.
I just took a gum. So I'm from Ancora Health. We are also interested in using these models to help with coaching people to live healthier. Well, one of the challenges we have is if you provide these information of patients to something like ChatGPT, you don't know what they do with that information. Are you running these models locally, or?
Yeah. So do you remember the slide I had with the big cloud? Yeah. So we're not using ChatGPT. We are using the GPT-4 model, which is created by OpenAI, but it's an instance. Microsoft has their own version of it. So we're using the Microsoft version, and we use a closed-off API. So we are running it in the cloud, and we have a secure API. So it's not going to OpenAI. It's not leaking. It doesn't retain the information. Doesn't retrain the information.
But you're hosting the API, or is the API hosted by Microsoft?
so the model is hosted by Microsoft. Yeah.
Microsoft does get the information, which is fine.
I mean, well, it depends on how you define this, because we are using, for example, I mean, every hospital uses Windows, right? And we are, for example, Epic is run on Nebula, which is a Microsoft server. So it's all within the Microsoft cloud, which are in European servers, and we have a secure API there. So it's all within the digital infrastructure of our hospitals.
Which has
I get it, but it's I get what you're saying, but it's not nuanced enough to say so the information goes to Microsoft, right? All right. Well, that's. I mean, that's easy. So.
But I mean, so the basic premise is that we need to have solid agreements on these type of activities, and that's all taken.
And we already have them, right? We're not doing anything new in that sense. Yeah. Right. And it's not even possible anymore to keep running these things all locally. So.
Okay. Another question? The same question. Okay.
I was not planning to talk today, to be honest, but you got
That's
Microsoft
okay,
here in the room, so I have to add to this comment. So the fact is, because we invested in OpenAI, so Amina Shah from Microsoft, by the way, I'm the technology leader of the healthcare team. So the OpenAI service runs on the Microsoft service VMs, you could say, but because it is part of Epic, or like, I don't know the specific context of this, but it's a service from Epic that runs on the Microsoft service. Microsoft does not use that data to retrain the Azure OpenAI service. Microsoft does not forward that data to OpenAI, the public model, and Microsoft does not own your data. The data is within Europe. It's also protected by the European Data Boundary Act. So I cannot pinpoint whether the data center is in Amsterdam, Ireland. Like usually that's the combination. Could be somewhere in Switzerland, Sweden also, but somewhere in the EU. Of course, Epic can answer that better. But the purpose is your data remains yours. We're not using it to retrain. And I have a link for you to share. I can share that for your software developer.
I think at the 5 o'clock drinks, a nice conversation is going to spur. Any last question? The last question. Sorry, I saw him first.
We'll talk later.
So my name is Stefan Verwij. I'm a data scientist at the Dutch Medicines Evaluation Board, and I'd like to continue a bit on this discussion because I was wondering, since you take information from these EHRs, do you have like an anonymization step, or do you separate information that it could not be retrieved back to a single patient? Is that an issue or something to take into account?
No. So the short answer is we do not anonymize, and we don't have to anonymize. And in fact, I really want to put out there that we should not anonymize, because you want the information that goes to the model to be the most correct information you can find, because if you put in fake information or information that is not there, then you increase the chances of hallucinations. So it depends on the obviously the use case, et cetera, if you need that information. But what we do is we make sure that we do it in the sense that we can use this information, and there's also personal information, legally, so we don't have to anonymize.
And isn't it so that anonymization also suggests that you're putting it outside?
Right, which we're not.
Which we're not. Right. So, but it's, I mean, it's a very relevant point. But yeah. Okay, thank you, Jessica, for a great lecture, and the follow-up discussion. I think is going to go on during the panel discussion that we will have later. For now, I want to continue the program with Marcel Alberti of HealthSage. And I think you've already got a lot of sort of voorzetten.
Yeah, exactly. Yeah.
So if you want to walk around, you can use that one.
Yeah, I think it's easier. Yeah. Okay. Because sometimes I start here and I finish on the left, and then it works, right? Yeah.
It works. Yeah.
I can't see the mouse. I'll do F5.
All right. Top. Oh yeah, sorry. Yeah. So good afternoon, everybody. I'm Marcel Alberto, one of the founders of Health HCI. So we're a startup. Oh, wait, I went a bit quick. Oh, wait, it has to only... It only keeps advancing. Oh, sorry, a small button. Yeah, let me do that again. One of the co-founders of Health HCI, a startup. We exist for about a year and a half, and we're training large language models, Gen AI, for healthcare specifically. Mainly from a data management perspective, so that's what I'll zoom into, but I also wanted to, I can maybe go into a few of the questions we just had on data as well. So we're building an open platform, you'll hear that coming back a few times, for Gen AI, which is obviously secure and private, to also integrate that in workflows. So what does that mean? Very high level, at the bottom there's a flexible infrastructure. We talk a lot about the cloud, but the models have arrived to your laptops, and either you have them or by end of year you will have them most likely on your mobile phone. So start to see a future where these models will be everywhere. These will not be GPT-4 big size models. These will be smaller models that are trained for very specific tasks, which has obviously advantages in terms of cost, speed, privacy, etc. So in our vision, then we move up to the platform level. There won't be a single model that serves all of healthcare, since healthcare is too broad, too diverse, too complex. But it will be a multitude of models, maybe even dozens or hundreds of models in an institute like this, as they start to specialize. And we distinguish three sources. Sort of on the left, models we train ourselves, the HealthSage models. In the middle, health models. These are models developed typically by mostly academic medical centers, especially in the US. They're developing, for example, cancer-specific models. And on the right are the general models. So those are the OpenAIs, the Anthropics, etc. And I think they all serve a purpose, serving healthcare, and then to drive a whole range of applications, right? We saw examples of what we consider third-party applications, so integrated into the EHR, which is probably the number one step to fight all of the administrative burden. But there will be a lot of other applications as well, whether those are imaging applications, remote monitoring. I think I heard Ancora there, so they also want to have AI. So that's our view of the future, what we're building towards. And we've started with training our own model. So what does it do? So it converts unstructured text. There's a lot of text, whether that's real-time or historic text that has been collected over the past 10 years, into FHIR, map SNOMED to it, etc. So it helps simplify data management, but it also gives you new insights. So very simple scheme of things. There's a lot of text flowing, whether that's letters, whether that's text that was typed in the EHR, that we start to structure. Basically, Jessica already said it, you can transfer it to code, basically, right? You start to convert language to code, and once it's code, you can start to automate things, add intelligence to it, build applications on top. We saw examples to reduce admin. There is billing use cases, and that's what we're working towards. And I also wanted to give a brief example of what you encounter when you train your own model, what you can do, what you cannot do. So this is a few examples how we started. So if you take, let's start with the chart. So if you assume GPT-4, I agree, Anthropic is the best one, but it's still very good, so it's also on our slide. So when you ask it to transform clinical text to structure, it's 85% correct. So late last year, when we announced the company, we trained a model called Llama 2 from Meta, so the parent company of Facebook. And you see it's about 5% more correct than GPT-4. And then the orange bar is based on Mixtral. That's from a French startup, probably the most prominent European startup in terms of LLMs compared to the American companies. And you see it moves up to 93%. So by specifically fine-tuning it, so it's not prompt engineering, we also do a bit of prompt engineering, but it has its limitations. But to really train the model, you start to be more correct in terms of transforming. But there's other benefits which we hardly talk about, or disadvantage of very large models. One is they tend to be slow, right? So a smaller model, this model is 4 to 5 times as fast, but also the cost difference is huge. If you want to run your entire hospital, everything doing GPT-4, it's probably a significant bill, but there's also an environmental footprint that you will have, right? The impact on it is huge. So in that sense, I think it's worthwhile to consider working with multiple models in parallel and for these models to specialize. So you apply the best model for the best specific, or for a specific task. Now we will be extending this in the future. You also don't need to believe a single word of what I've just said, because it's open source. You can download it, you can try it, you can further train it, you can build applications on top, and you can contribute it back. So that's of course the vision behind open source. If you try it, you build something on top, you open source it again, and together you basically start to collaborate and improve things. It's on Hugging Face. I'll have a link towards the end of the presentation. It's a bit the same title as Jessica. We didn't pair together, but it's only the beginning, right? So I think there's a huge amount of applications, right? Because if you start to work on all of the different data types, you start to structure those, you start to truly understand the data, you can do a lot of things. Much more comprehensive pictures. I do think we'll go into clinical decision support, not this year, but it will come, and it will come very fast. Well, I think Jessica gave the same example. Treatment adherence, matching it to protocols, can be your own protocols, can be guidelines. I think there's a huge amount of applications possible. Yeah, and I think that's the future to become. In our case, you can build applications on top, share those applications. So the vision is very much, we lay the groundworks. We make sure there is a secure platform, that there will be base models available. You will have applications, but the future, I think especially also for well, institute like yourselves, right? ETZ and UMCG would like to be at the forefront. You can actually contribute to that future. That's it. If you want to go on our webpage, you will find the links to the models. You can download them, you can try them. We're of course very curious to see what you think of them. And also please contribute back, because that's part of our vision. Thank you.
Okay. Thanks, Marcel. And of course, again, the floor is open to any questions for Marcel.
Yes, hi, Dirk Willem Bonnik. I was wondering, you say there will be clinical support. How do you think, what do you think about the legal aspects and the...
I think the legal framework will and have to evolve over time, right? It will probably go at different speeds. I think
that's the problem, probably.
I think the US, yeah, not just legal versus technology, but I also think geographies, right? I think the US will probably go faster than Europe. So I'm not saying it's going to be there tomorrow or this year, but I think especially if you combine it with some, let's say, older AI technologies, right? So not everything needs to be solved by Gen AI, but also more reproducible AI results. I think it's not too far of a future.
Well, I agree, by the way. But,
yeah.
But I was wondering what you're thinking.
Yeah. Yeah.
So Jessica mentioned a 2-year time window for certification under the MDR, which luckily enough nowadays it's going down again, but it has been really, really poor.
That's a big challenge.
And on the US side, not only a really large market potential for industry, of course, but the FDA is also quite innovative.
Yeah.
When it comes to new regulations, draft regulations on the use of certification for AI, which I don't see in Europe at this time. Do you have any?
No, I think it will take time. Yeah. We are starting with a slightly different view of it, using large language models for some of these certification programs, because you can actually automate a lot of it. Like in the ideal world, I think Tesla even did it with their cars, and they started to send results directly to their regulators. I think we're far away from that, but at least maybe we can sort of speed up the initial steps, all the paperwork.
The legal GPTs, etc., are they're sprouting. Yeah.
Yeah.
Any other questions for Marcel? Yep.
Hi, I'm Javor Gustel from G2 Speech. You were showing the graph of accuracy,
and
you were comparing OpenAI to Meta to Mistral. what is the accuracy of a human being in that graph?
Oh, we haven't compared that yet. No, so I can't tell you.
I wonder how they compare, obviously, in accuracy to
Yeah,
a person.
it's a very good question.
Yeah.
So we're going to do research with two sort of academic hospitals, and from there you'll see the results, but we don't have those yet.
So for that purpose, it would be ideal if you would have an environment where you can collaborate with those.
Exactly.
Well, we're working on that.
Yes.
Together.
So,
okay.
Yeah.
Any other questions for Marcel? Yeah.
I'm Casper Porter. I'm a medical student doing my thesis on AI and radiology. But I was wondering, because I'm hearing a lot about, the clinical aspects, but what about just plain old scheduling with AI?
Yeah.
Because getting someone on time to an MRI or a CT is, I think, next to, adverse events from medications, the biggest thing people complain about having to wait 6 weeks for an MRI.
Yeah. No, look, I agree with you, right? So that's why you see a lot of companies these days starting especially on the non-clinical use cases, because one, it's a big burden for the health system, right? On the other hand is you avoid the MDR in that sense, if I were to put it simplistic. So scheduling is definitely useful. We're not working on it, but there's companies working on it.
In the discussion we had prior to the start of the meeting, we also talked about this. So what we are seeing developed here is the data stream is being activated, is becoming computer readable, and from that point onwards, doing things like scheduling becomes much easier. Whereas now you have 10 different Excel sources and different ways of formatting things, and it's just a big mess.
Yeah, absolutely. And also all the historic information, right? Because EHRs at countries like here, but a lot of other countries have been around for quite a while. So there's a ton of data, especially for a research institute like this, like here and others in the world. So if you have the data correct and complete, you can do a lot of things. But you need to do that groundwork first. Well, you can all start with the applications, but I think the groundwork is more important first, and then you more quickly innovate at the top layers.
Any last questions for Marcel? Of course, he will be part of the panel discussion as well. Yeah, Jessica.
I just want to add one thing, because you've touched upon this, but I think it's really important, especially for here, is that you are, as Health Stage, creating the first steps to make data more available.
Yeah.
So if you're translating the regular human text to code, then you can also do more research with it and create models. So yeah, I think that the steps you are taking are absolutely amazing.
Yeah, thank you. It's a good addition. Look, the other thing which we're also doing to make data available, so we also developed our own synthetic data set. It's also available, so you can download it. You can expand that data set. And we also have another university hospital, which is also expanding our sort of a synthetic data set, because that data you can widely share, which is then can be used by others to either train or add to it. So that's another element of how we're trying to make things a little more open and innovative.
Okay, thanks, Marcel. And next speaker, Els Makelberg. A little applause, thank you.
Well, whilst they are doing the technical stuff, I would like to start with two preliminary remarks. First of all, during the other presentations, especially the picture that you showed us, with the people with the screens, I suddenly felt a dinosaur, because I was there already at the time when computers started being introduced. Yes, I'm that old. And then the promise was, and now I'm looking at Jessica, who's there, everything's going to work better, faster, quicker, and the doctor will have more time to spend with the patient. That's when I had presentations with cartoons. We still used people making pictures at that time, of the doctor sitting behind the screen, not seeing the patient. Yes, that's become reality. Just want to tell you. My second remark is that what I'm going to present you is not loaded with fancy pictures and whatever, and it's solely based on work of a couple of human brains. Now, I'm part of a project that is called the ELSA Lab AI Northern Netherlands, and you've seen it on one of the first slides shown by you. It was on the, if I'm correct, that slide, second one or third one, the third one, and I'm part of that project. But in general, I work at the Beatrix Children's Hospital here at the UMCG, and I'm an ethicist. So what I'm going to talk about are this acronym is about ethical, legal, societal aspects, and as it is my specialty to talk about ethics, that's where the emphasis will be on. I understand it's the top.
The big button.
Oh, the big button. Oh, the other one is a pointer. Yeah. So that's my only disclosure I want to give here. Otherwise, I don't have any affiliations whatsoever with whatever company. So that makes it clear. And you can learn a lot more about this project on this website of the UMCG, where you will find more. For me, when I talk about ethics and AI, this document written by the Nuffield Council on Bioethics, and I would really encourage you to follow the Nuffield Council, also with your local councils, of course, but this one often produces extremely well-written papers. And they wrote in 2018 this note, and to me, the lead of what I'm doing is this one. So I just copy-paste it in almost every talk I give. So the key challenge that we have will be, and I would say is, we're already there, ensuring that AI is developed. So that's what you are, or many of you are doing. So that's a no-brainer, everybody agrees on it. But also that it's used in a way that is transparent, and many of the questions that you already posed and asked were about that, and compatible with the public interest, whilst stimulating and driving innovation in the sector. This also to tell you ethics and also legal aspects. Just give answers, yes, please. Ethics, also legal aspects, are not about stopping innovation. It's about doing it in a responsible way. And responsible is an enormous term that covers a lot of things. And I want to tell you a bit more about what we've been doing. So in this project, we're trying to contribute to trustworthy human-centric AI. And here you can see what the work package ethics that I lead is about. What we try to do is help those people who use or who will be the ones who will be the result, will actually accept some of it, of the AI, make sure that they also have that ethical competency to think critically about what they are doing. It's important to do that because there is a paper out that has analyzed how much developers of AI think about aspects that are in the field of ethics and the legal field. Almost never. In all those papers, it's about, is it technically feasible? Many of the questions that you have already asked, but I haven't counted, but I just, like this, I can tell you that you have already asked more ethical questions than there are in all those papers. If you want a reference, I can give it to you. I haven't with me now, didn't put it in this slide. So what we try to do is develop some guidelines on how to do that. Now, what I want to share with you is one of the first results. That's the human brain trying to think about what is going on. In the project, we look at 4 use cases from the perspective of Elsa. And this is a result of a use case in genetics, but we also have one in, where is Claudine? About monitoring. We have what about synthetic data? LLM is a use case. And I'm happy to announce that we have a 5th use case. And that's at the pediatrics hospital where I work, so that's where we have the connection. And this is interesting because this really is about the development of a clinical decision aid based on AI, and it relates to ethical decisions that need to be made. So it's very exciting to do that, and we have a new researcher on that project. She's sitting there completely at my right, your left. So this is an exciting field for us to explore. But what we've done first is try to get an answer, or at least to provide a model, how to think about AI inclusive healthcare. Oh, is something going wrong there? I thought that someone was falling or getting... and it has already been mentioned that we can develop a zillion things, but if people do not want to use it, it's a waste of effort. You mentioned that before, and I know wherever I go, people constantly tell me, yes, we have this application, people from the AI field, we have this application, but the doctors, the healthcare professionals don't use it. So what do we need in order to ensure that you can explain where the trustworthiness is? And we call that we are looking at AI from a more institutional perspective. It's not only about individuals using it, it's broader than that. And we talk about epistemic trust. So can you rely on what's going on? And how do you do that? So I will take you through that model. Okay, I have the boring pictures, but I will run you through it. So this is, in our field, in philosophy, a model that has been used before. We applied it, but then I will show you that we broadened the perspective. We have several conditions that we need to address if we want to make sure that people will trust it. So the first condition is that reliance condition. So here we talk about, okay, we have AI inclusive healthcare, and we get a certain kind of result from that. If I would translate it to LLM, we have a great text that helps the doctor. I'm looking at you. You're the expert. Okay. So this condition is, and I'm using the language that we use within more philosophy, but I guess that you can understand it. P is a reliable output of reliable AI inclusive medical research. So you need to know what it's about. This is what we got in the presentations before. There is reliable research, so that it says if you use this LLM, yeah, don't worry about it. It doesn't do any strange things. Now, I do take it for granted that it's reliable research, that there are experts who have looked at that and that we don't have to worry about that. That we have experts who know that there aren't any biases in there, and so on and so on. And so also that and/or, this is an extension of already existing standard non-AI medical research and practices carried out by S, and S is the medical professional, or whomever you want to talk about. So this is the first condition. You have to meet that. If you don't meet that, you could say that, okay, the trustworthiness is gone. This is kind of underlying also the EU framework of trustworthy AI. It's a huge document, but you could say that it's summarized in some of what we are showing here. And this is foundational. Now, in this reliance condition, well, this is self-evident for all of you present here, is that you have to recognize that there is, of course, a potential that AI will make erroneous decisions. We need to be aware of the difficulties in validating the outputs of the AI systems. And of course, another part, and there are many more questions that we can address, but I just mentioned a few, we need to be very much aware of the inherent biases in AI. What do we put in there? How reliable is that? Okay. Let's go to the next condition, and that's what we call the professional trust condition. So it means that this professional is reasonably knowledgeable about the context of the generation of P. So the training model that we were shown, everybody needs to know about it, so that they have an understanding of what is going on. But they do not need to be experts on it. That's why you had that layered model. So thank you for showing that. It really ties in very much with what I'm telling you now. And there's always that interaction. It's the interaction between what AI gives you and your own knowledge. That's how, at least in my career here, I've seen happening all the time with new technologies, with new ideas, is that professionals, and that's why they are there for, let it resonate with what they already know. If it doesn't fit, you have a new discussion. This means that in building these systems, these are types of questions that you already have to think about, because they will come. This is one of the most familiar remarks. But my intuition says, you probably recognize that. With intuition, professionals usually mean I have a long-standing experience, haven't always systematized that, but this is what I think it is. So that's something we need to address. So if this professional has sufficient reason to think I can trust this, then we add and build up that trustworthiness. Yeah, self-evident. We need to work on that. The third condition is the communication condition, because there's always that interaction between, okay, we have this information and there's a patient. Again, it will resonate with what you've seen. Sorry, am I standing in front of it? With what you've seen in the previous presentations, because what does the patient do with it? How do you communicate about it? How much does the professional need to know about what this information really means and implies in order to be able to tell it to that patient? And on the other hand, how much does the patient need to know about AI? A while ago I was somewhere and there was immediately a question, but we cannot educate all citizens about AI. Or another one, yeah, but I will have to spend so much time explaining what AI is about. That's not what it says here. All medical professionals select information when they tell it to the patients if they want to inform them. But this means that you really have to know what your selection is based on. Is AI becoming a third party in the communication? This has happened with that computer screen. It became a third party, but it wasn't only a third party, it was like a wall. Your picture showed that. How is it going to be? These are questions we really need to address. And so what to communicate about AI? The fourth condition. So now we're here with the member of the public or the care seeker or the patient, and it's about this, what we call the recipient trust condition. So yeah, somehow we will have to educate the public. But what is education about? It's not just, trust me, I'm an AI expert. That's the same as saying, trust me, I'm a doctor. Well, it doesn't tell me anything. I don't know what type of doctor you are, what your expertise is in that field, and so on. You can see that we've been a bit elaborate here in explaining this condition because it becomes quite difficult here. So it says M, so that's the one who is a member of the public, understands to a sufficient degree what the proposition is, what's the outcome, and the context of the generation of that. That's one of the things that's been going on with using the LLM here at the UMCG. There was immediately a good explanation. Well, I'm going to say it neutrally. There was an explanation on what it was about. Yeah, sorry. What it was about so that people could understand what happened. If you ask a question, it's not that AI, as it is in the general public's mind, will answer you immediately. No, there's always a doctor checking it. I noticed that people really triggered on that. General public said, oh yes, there's still the human party involved. Okay. We need to do something with that reflex. We need to be aware of it. So it's about the reliability. It's about a certain type of understanding. So what kind of information do you have to give? What is sufficient information? A question we all need to address if we really want to have an epistemically trustworthy AI. And so how much info about the AI itself? Now, we have the fifth condition, and that's the one we added to the existing model. It was an existing model that was more only a philosophical model and not applied to anything. I have to tell you that. And we said there is also that background condition because, and that's what we saw already this afternoon, you cannot talk about this, you cannot develop anything if you do not also think about the legal framework. And I think that is foremost on people's minds, as I could see this afternoon as well. And I must admit, if someone talks about the AI Act, and now I'm looking again at you, I say, yeah, and not, oh my God, at least we have something. It's good to have opponents. And I'm playing the devil's advocate, of course. I know how difficult it is, but on the other hand, we at least have a framework. Otherwise, what are you dealing with? Okay. So this background is really important to be aware of, but not only awareness, because everybody will say we are aware of the legal factors and the ethical factors and so on, economics. But making explicit what you do with it. And that's quite challenging. Because when we look at that background, well, I just started piling up questions and questions and topics and topics. And I could go on for for many, many slides. But I think that some of them are already addressed in the legal framework, protection of potentially sensitive data. Again, yes, that comes to mind very quickly. But there's also the part of justice and equal access. We are living in a worldwide community. Think about Corona. Suddenly, it wasn't about our own country, even though the reflexes later on when we had vaccines was, oh, let's protect it for Europe. There's a similarity here how is the AI going to be used in that worldwide context? Is it something for the affluent societies? Or are we also building systems to help people in countries that are not that affluent? Might seem a question that is really flying over our heads. WHO is really adamant that we also take up that challenge. Beautiful document of the WHO setting out what questions we really need to address. One that is really very close to my heart, and I don't know the answer yet, is this one: green healthcare. We're talking about making sure that we are less wasteful in healthcare, because we have quite a big climate impact. And it was touched upon earlier on. But how are we going to show our responsibility and take also on accountability for the carbon footprint that we are making with all these systems? How are we going to do that? And I was wondering, is there anybody aware of, or maybe willing to start thinking about, what I would call a climate impact assessment of AI? If someone is willing to do that, and or knows about already existing models, because my wish, and this maybe a personal wish, but I hope that many people share it, is that every time we start developing an AI tool in healthcare, that we do not only the things that we already know, like the DPIA, the privacy impact assessment, but that we also have the climate impact assessment. So please come to me. I'm really very willing to think about that, and let's do something about it. I'm becoming a bit like a zealot here, but it's impossible to neglect this if we take health seriously, because I look at it from the perspective of the broader issue of health. And health is not only about what happens in the hospital. It's also what happens in the environment, climate, and so on. So this is what I think one of the huge issues if we look ahead. Independence and commercialization is an issue that I hear a lot from the public, the broader public. They want to know whether what we do is something that we keep in our own hands. Well, there was already a lot of discussion about it. How do you do that? It's not a new question that relates to AI only. The developments are going that quickly that people are more concerned about it. Workforce, that's one that I added there. And we heard from the first talk that it's going to help us enormously. Now, I mentioned that I'm a bit of a dinosaur, where we suddenly saw that the computer did not help people get time for their patients. And we needed more and more people to build all those systems. And we needed more and more time for people to explain how you use it. And then we needed more training. Will it be different with AI? I don't know. Probably if we convene here in, I guess in 10 years already. Let's not say 5 years, but 10 years, we will get more of an answer to this. I guess so, but we shouldn't wait for that. That's why my conclusion is, let's be Promethean. I don't know whether you know Prometheus. That's the god, semi-god, who brought fire to humanity because he thought we needed that. He felt so sorry for us being cold and not being able to make things. His name means he who thinks ahead. What he didn't foresee is that the gods got angry at him. You can now fill out who those angry gods are in our society. So they tied him to, was it a tree or a rock? A rock, I think, yeah. So his liver was picked and regenerated, and it continued and continued. But are we willing to be Promethean? Think ahead and answer, all of us together, these questions, because the trustworthiness of AI, I think, relies quite a lot on our answers. Thank you.
Thank you. Thank you, Els. And so it's tempting to now open up the floor for some questions, but in fact, after this is the panel discussion. So what about we get all the speakers to join in and...
because I was already addressing them, so...
and that's it, and it's always very... it sparks the discussion, your lecture. So thanks so much. So Jessica, Marcel, if you want to join us, and Job, you're going to be moderating this one. I'm going to give you the mic. We can do it together, maybe. We can also have the catch box for the crowd, maybe.
What do you want us to do? Because yeah, and I think our voices can be heard like this.
All right. Any first questions from the audience? Yep.
Yeah, the last presentation made me think, and I was wondering, is it valid or necessary for a patient to have an option to completely opt out of AI-included healthcare? Because if you look at your system, if you use the recipient trust condition, then you can see AI like a bone marrow biopsy. It is a tool we can use. Maybe it's trustworthy, maybe it's not. The patient can say, I don't want a bone marrow biopsy, but still treat me. Or if you look at it like a background condition, then you can say, it's similar to a patient saying, treat me, but I don't want to be in the hospital. And of course, that's not possible. So the question, do you guys think it's necessary for a patient to be completely able to opt out of any AI-involved healthcare?
My first reaction to this would be, nowadays, if a patient comes in, imagine that we don't use AI yet, because we do, but anyhow. It could be about whatever they want. There's the medical professional who has their own boundaries. This is what we as medical professionals can do or cannot do. You do not want to have an MRI scan, even though I deem it's really necessary, because otherwise I don't know what I'm going to do next. Then think about the consequences. I'm putting it very black and white now because I want to clarify the point that as a medical professionals, you need to have the tools that are really necessary to take action in the best way. And if I would come to you and I say, or give me a condition that I really need an MRI for, so that you need, or something like that, you know, and I say, I don't want that. You probably would say, but that means that I can't offer you anything, because I don't know. It could be that AI will be one of those tools that gives the professional such a big help that you will have to say, okay, maybe you do not want to have AI, but this is what we use. But it depends on what we're talking about. That's why I was trying to give this example to make clear. We do not need to think that with AI, everything changes. We always need to tease out what makes AI different from, for instance, that MRI. Does it clarify it a bit, or is that?
Yeah, but so your opinion is that. So your opinion is that this is not a valid question for a patient to ask, because there are some situations where you have to say no, it's included now. There's no escaping it, even if, as a patient, you don't trust it.
I would say it's a very valid question for the patient, but it's up to the medical professional to understand that or to ask, what is this question really about? Because I guess that in many cases it will be about not understanding what the AI was doing. How often does a patient say, I don't want an MRI? Then you ask why. That you think, but this is not a reason that I would want you to take into consideration for a valid judgment. So I'm going to have a conversation with you. And I guess that could be the case. And there could be valid options. But then as a professional, if you can't, get to actions that you can be accountable for, then you can't do that.
Jessica?
I first want to know what are your thoughts?
Well,
and then I'll respond.
Okay, yeah. Well, my
I have a
thoughts
strong opinion on this.
are, it depends on how you view AI, if you view it as a tool or if you view it as a paradigm. And I think if you view it as a tool, then the patient can say, okay, I don't want it used for this specific indication, sure. And then you go without it. If you see it as a paradigm, then there's no escaping it, and the patient would have to conform or get out.
Okay. So I agree with you. What do you think the EHR is? Can a patient opt out of using an EHR? So it's an electronic.
After the fact, yes, they can say erase all the data from the
No,
EHR.
no. I mean, I want. What kind of physician are you?
Internal medicine.
Okay, I'm going to you for whatever anemia.
Yeah.
I say whatever you do, don't use the EHR.
Yeah, I don't think that's possible.
Right.
Now.
So the question is, AI, not necessarily now, but in the future, right? Be a Promethean.
Mm-hmm.
Is it going to be so embedded in our society that it's inevitable?
Yeah.
And I think that is where we're going to.
Yeah.
I also think, but this is a personal opinion, that is a good thing. But then you come back to, we are now in sort of a twilight zone where we're starting to use AI. So it's easier to technically opt out of applications. But I think AI will be embedded throughout the entire hospital, throughout your entire life. And then opting out of AI is practically impossible. So from that standpoint, I think you have to make the comparison, not necessarily now, because you can't, but in a couple of years, be a Promethean, that the application of AI in healthcare is just as it is in society. It will be fully embedded. And so it's therefore kind of not possible to opt out. Yeah, but
that's not the kind of conversation.
Let me get to so the question is that preferable or not? And what should we do now? And I think the one of the questions Alice poses was really important. Why does the patient want to opt out? It's usually a lack of trust, and there are many, many reasons for the lack of trust. But this is where we, as our pioneering hospitals, A to Z, UMCG, we step in and we say, we are showing you that we are doing this in a responsible way, that we are addressing the privacy issues, the bias issues, et cetera, and we are showing you that, I mean, we are both medical professionals. The most important thing for me is the well-being, the welfare of my patient, right? So I wouldn't be using this if I didn't think this would benefit the patient on an individual level, but also on a societal level.
Yeah, but I think the difference between the EHR as a general fact and AI in healthcare is that this is a very high-risk situation. If you look at an EHR as just a paper where that notes certain figures that have been jotted down, and the AI and the inherent biases of hallucination that, I don't know, at least the last presentation said we cannot completely get out. You cannot guarantee me that it's out.
No, but what you're saying is that we need to perfect it in such a way that it's good enough for healthcare. And I agree with you on that.
That's the first condition that we mentioned. If you don't have that...
Just a brief note in between. Sorry. So one question, Marcel, is there an opt-out button in health stage applications?
No, there's no opt-out button in health stage.
Right.
No, I think, yeah. But you're asking the AI founder. I think we need a button to opt in much more people into AI.
I think you shouldn't have an opt-in at all.
No, but what I mean is that because I'm also a patient, right? I would love for my physicians to use AI on me all the time, and then they can still ignore all the results.
So we could have an opt-in versus opt-out discussion, not necessarily for should they opt out in healthcare, but in general, right? So what happens with one of the important things about AI is that there is an inherent risk of bias that you mentioned, right? That some people are underrepresented in our data sets. For example, people of lower socioeconomic statuses. If you have an opt-in system where people have to say, yes, you can use my data to create a model, you know which patients are not opting in?
Yeah.
The minorities. So there is and I'm referring back to you because you're the ethics professor here. There is a trade-off there where if you are too focused on the individual, and I'm not saying that there is a good or bad here, it's an ethical discussion we have to have as a society.
Mm-hmm.
If you're too focused on the individual and you're saying this is an opt-in thing or people can opt out or whatever, you are inherently introducing bias into your models. So I think that is also a societal thing we need to address.
If I may,
It's great to talk about biases for a while. Oh, Bart.
Nice.
Sorry, it was not about biases, but I thought the the green aspect I think is also an important point for to bring into the discussion. And I was surprised. I recently saw there's going to be a plan with SURF and other organizations to build a so-called AI factory, right? A really big compute center, which is likely to be hosted here in Groningen. And that from the 500 expected million investment, 1/3 of that goes into energy. So that blows my mind. And so there's a real urgent need for further exploration of that. And I think one of the leads I saw in your presentation as well is now what we're doing now. We're in the early stages. So we have a simple question and we use a 175 billion parameters large language model to answer a really, really simple question. And I think in the future, I mean, we're going to move much more towards these specialized small language models that are going to be much more not neutral clearly, but I mean friendly. But maybe that's a point where we can also get some of your opinions on how is that sustainable, how is a sustainable future for this type of models.
You want to go me first? Since you're looking at me, okay. No, but I think it's right. If you look at what's hampering also the development of AI, right? It used to be things like talent or data, but now it's energy. There's not enough energy to develop the super large models and then to run these models, which is why I had it on my presentation. I think you will have a collection of models and they will serve specific tasks. And for a simple task, you'll have a simple model that maybe runs on your laptop or your phone. And then you will still have big models, right? Because if you will still have very complex questions and problems in healthcare, but then you send the big problems to the big models, basically. I think that's going to be the future. It will take a little bit of time, but I think the environmental impact, energy in general, whether it's to train or to run these models, is a big challenge. Right? Because if you think of it, there's only a very small percentage of population today, regardless of whether you're in healthcare or not, who's using models. So imagine everybody is going to use these models, whether you're in banking or healthcare or for your schoolwork. I have 3 small kids. Right? If they're all going to use AI, that's a massive explosion of energy. So something we need to be aware about.
Can I just respond to that? I think that what we really need to do is also change the language in which we talk about it. It's not about shortage of energy. It's about us using too much energy. So how can you make the system run on very little energy? Because otherwise it's going to be an expansion of what we need, and we're never going to get that if we want to have the children still being around. I'm going to be a little bit morose about this now, but if we do not change that,
I'd like to connect
then
to
we,
that,
yes,
Els,
thank you.
because if I'm correct, most of the energy goes into cooling of the systems, and I think there's also into cooling of the systems. So I've been told that there's also a lot of technological innovation on that side, right? So that the computer systems themselves become less energy consuming. So what do you expect of that?
I think it's going to be both, right? Because I think it's inevitable that the use of AI is going to go up. right? Way more than we are today. But I do agree with you. There's a lot, and with you, there's a lot of innovation possible to reduce its footprint, right? So Bart gave the example of GPT-4. It's not fully clear what their architecture is, but most likely they will run 175 billion models to give you one answer. But there's already models which are 1.3 billion, right? So that's a fraction of. Now, of course, it can't do a 1.3 billion model can never do a very complex, well, at least now, not a very complex task, but it can do the simple ones. So I think it's going to be both. So I think the energy consumption, whether it's for development, cooling, inference, is going to go up significantly. But there's a lot of technical innovations also needed to minimize that. And beyond that, you can have a discussion whether you want to apply AI or not, right? Should we apply it to everybody? But I think it's going to be a very difficult discussion in the end.
I wanted to go a bit back to the bias, because during every presentation I was wondering, because the inherent bias in AI is also something in literature I came across a lot, but how is it different from our own bias? Because isn't it more that we know our own bias, but it's worse instead of a blind one?
Yeah, I love that you're touching upon this. So a language model is trained on our own output, right? So it's actually a mirror to our own biases. And this is a comparison that I make a lot, is that now, so now that we are trying to create an ethical framework for AI, I think we should do the same for us. But it's a lot more difficult. Yeah. And to make the comparison with people, when we did the summaries research, you have the skeptics who say, well, how do you know? Do I have to click the link always to check if it's correct? Well, I mean, you're getting a transfer from your colleague, and we all know that you have some colleagues you trust 100%, but there are also colleagues where you're like, well, he said this to me, but I'll check it for myself, right? So we already know that there are inherent biases in us. And I think what I actually like about what is happening with AI is that we're putting AI on a high standard. Let's do the same for humans.
Yeah. And if I can also respond first. Yeah. I was at the large conference of public health, and we had a session on AI and will it increase or decrease health inequalities. So we touched on the biases. And I had to take the not very agreeable position that I said, no, it won't increase biases, because my point was it's us humans who do that. But anyhow, there was a room with over 200 people there for that session, and I asked them, who uses databases? Everybody raised their hands. So I said, keep your hands raised. And then I asked them, who has ever checked the databases that you use on biases? One person was left. That's what I think. Oh, I'm really, I got angry there, because I thought, you're in public health and you're always talking about health inequalities. You don't check your own databases, or the databases that you use. Why is there only one person in the room who is doing that? So I said, I rest my case. And I think this is a very, very valid point that you're making. Yeah.
So, hello. The three of you probably are going to lots of conferences and do lots of these panel discussions. If I would give you a magic wand to frame future discussions on AI in healthcare, what would it be about, starting with Els?
Can I first think about that?
Yeah, just over drinks, you can later tell me, but I'm...
No, I just want to... only one.
So, because now it's energy reliability biases. I think these are big themes that are coming along, but what are the things that you actually really want to talk about, that are really important? How do you want to frame this discussion?
Yeah, so I am going to touch upon Else's field, because it's not my field of expertise, but I think it's the most important thing. We have to have a societal discussion about the ethics of use of AI, but also the ethics of not using AI. When we are postponing the implementation of AI, and I'm granted, when I'm talking about AI here, I mean a model that is that is performing well. And just for the sake of the argument, please, let's leave it at that.
Is dealt with.
Yes. And we are postponing the implementation of these models for legal reasons, for trust reasons, for adoption reasons, for trust from the healthcare provider who should use it, but also from the patients who say, I want to opt out, et cetera, et cetera. Yes, we all need to address that. But what happens now is that we halt the progress. For example, the MDR, what I talked about, it takes about 2 years to get through that. But in the meantime, we're not using a model, and we are also doing harm by not using that model, right? Because we can use a model, for example, to improve the diagnostics of, let's say, lung cancer. And let's say that we can improve that with 5% when we compare to a physician. What we now do is we don't implement that because we haven't addressed the legal stuff. We haven't addressed who's responsible when a mistake is made, et cetera, because I will go to the tuchtrechter, right, as a physician. But in the meantime, that 5% of people that we could have had an earlier diagnosis or a better treatment, we're not using that. And I want to have that discussion with society.
Marcel, your magic wand.
Yeah, it's going to be largely along the same line. So I think we should not forget about the benefits of AI. It sounds very obvious, right? Because we can fear of a lot of things, but they offer benefits now, right? So let's use them for the benefits that they have. And then let's focus on data and transparency. Because I think if we improve the data, but especially if we're transparent about it, because we know there's flaws in the data, just like there's flaws in the research or in the models, but at least be transparent about those flaws, because then we can collectively also start to improve them together. I think that's the only things I want to add. For the rest, I'll go with the things that were just said.
And I've come up with mine. I really love that, because intuitively I wanted to say ethics, but I can't say that. So thank you so much.
You're welcome.
But then I would also like to have a discussion about talking about AI probably not being the magic bullet that we're looking for. That's it.
Beautiful. What would you like them to talk about?
Oh, great.
I'm asking the questions here. I'm not. I'm going to think about that and over.
Can I have a go?
Yeah. One go, because Terra was before
okay,
you,
okay.
but a quick go.
I think it's especially for Els, but also for the two of you, and maybe a presenter as well. Treatment relationship, communication. Els elaborated on that topic using the slide, and I saw communication between physician and patient. What's the future treatment relationship when AI is an agent in that relationship?
So we have to define agent here. Do you mean an autonomous agent? So Els put on a slide, the AI makes decisions. Well, that never happens now, right? We can't do that legally. What the AI does is it provides a suggestion.
Well, I think our other presenter was already being Promethean about that.
I agree with her. I was just saying I think it's coming.
Right.
It's coming.
But
yeah,
today
right.
not.
And that's your question.
Yeah, that's my question. Yeah, because
Right.
if we are being Promethean here, well.
Yeah, so you mean with agents, you mean autonomous agents. The AI makes a decision.
I mean, just like part of a team, maybe.
Yeah, but I think that's a very important distinction, because that's also a legal distinction, right?
Yeah.
We haven't solved the legal issue of who's responsible yet. Whether that be an AI tool that just presents a risk. So for example, the patients that is in front of you with this X-ray has a 80% chance that this thing is lung cancer, for example. That is currently the setting of how we use AI, right?
Yeah.
It is presenting you with a risk, and I as a clinician will weigh that information together with all the other information.
So, but the type of relation would be more a legal one.
Well, so in
Instead
this
of
setting, currently,
yeah,
I am always responsible.
Yeah.
And that is one of the issues we haven't solved yet, because, and that is why one of my stokpaardjes is the balance between AI literacy, so what I should know as a clinician, and AI explainability, what the manufacturer has to do in order for me to understand what the model does. There's a balance there because you have, so that is AI literacy, AI explainability. You also have AI interpretability, and that means that is it even possible to interpret a model, to have it, to explain it? So there are very complex models that are uninterpretable. No one knows the decision tree, so to speak.
Just gives a number.
Right.
Yeah.
But what you can do, and that is post hoc explainability, is you can make it insightful more or less how that worked. But there is a balance there with responsibility with the manufacturer and with me as a clinician. And we haven't solved that because legally I am always responsible. So then you have the following scenario. The x-ray and the patient before me, the model says it's 85%. Well, good luck, right? If I say this could be lung cancer, we need to do a biopsy, whatever, and I am wrong, I am responsible. But there's also a 15% chance that the model was incorrect, right? Or you know what I mean?
Yeah.
We can't, so to go towards your question, we need to solve that legal issue first before I can actually answer that question.
Okay. Thank you.
That is my my take.
So how interpretable is your intuition as
Right.
Yeah.
Not. But I can try and explain it to you, right? Post hoc explainability.
I have an onderbuiksgevoel.
Right.
Gut feeling. Yeah.
No, you continue. Okay. First of all, thank you all for the talks. It was very interesting for me to hear you all talk about it. And to think ahead even more, you told us, Jessica, that the GPT-4 models right now are not adding information, they're just restructuring it. But I'm wondering if it does start adding things, such as if we put it in a scenario that you as a physician are in a room and the speaker is standing there, and you're telling the patients, well, we're going to do this. And the GPT-4 model says, well, here's a suggestion, you should do this instead.
Okay.
Is this a possibility or?
Definitely yes. So let me make something really clear. When I say it is not adding information, I'm specifically talking about the functionality that we tested, right? So that is the summaries functionality for outpatient visits with where we have the model with a low temperature, meaning that it can't, vary a lot of the output. And we have a very constrained prompt. So the instruction to the model is very constrained of what it can and cannot do with the information. Obviously, if I have a different application and I don't have these constraints to the model, I should say, obviously, then that is a risk. And then the question is that something you want or do not want? And currently, when you do not want to you do not want to fall within the MDR, right? When you do not want that the model suggests to do something, then you need those very strict constraints. So for every application that you do, you need to think about what model do you need, what are some settings of that model, hyperparameters, maybe I'm going too deep, but what specific prompt engineering do I need to make sure that it does not hallucinate? And you need to prove that it doesn't hallucinate. In the future, and that was my last slide, yes, obviously what you want is you don't want it to hallucinate, but you want it to be able to answer more freely using the information that you provide. So if you are versed in large language models, what you saw me do with, if you remember a slide, I had the GPT model, I had domain knowledge, and I had patient information, and then that was the holy grail, right? What that was a RAG flow, so a retrieval augmented generation, and that is a way of making sure that the model only gets information from a specific database. And that is also a way of reducing hallucinations. Can we reduce it to zero? I don't think so. But then we go into the ethics. Is that a reason not to use it then, right? Does that answer your question?
It does, but I'm also wondering what your thoughts are on this. Like, would you want a GPT model to give you suggestions on what you
Yes.
should do? Okay.
Yes, because
Okay.
no, seriously, I'm an ICU physician. Every week I get a newsletter. It's critical care reviews if anyone wants it, and it's a like a summary of medical research. And I just look at the titles, and I think this is interesting. I look at the abstract, and oh, that's interesting, and maybe 1 or 2 full papers I will read. That takes me forever, and I've missed a lot of information. And what a GPT model or what a large language model combined with medical literature does is it makes that available to me. So I am missing a lot of information. I do not know what I'm missing, right? And I think the combination of medical literature with a large language model makes that information available. And yes, then you should combine it in the future when it's safe, blah, 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 with individual patient information.
Thank you.
All right, thanks.
Magic wand guy, yeah? So I thought about this. And I read this book by Evgeny Morozov called The Net Delusion, his first book. And it is about the scale at which you discuss technology. So when you say internet is ruining our youth. Internet is the savior of medicine, things like this. Internet is not the right scale to discuss this, or Facebook, or anything like this. So AI, I think the same thing is happening. It's too big of a container term to really have a fruitful discussion. So what I would want to have framed during these panel discussions, what are the red flags in words that we should stop discussing because it's not specific enough?
Oh, hype cycle.
Okay, hype cycle.
That's my word.
No, but AI, I think to have a fruitful discussion, the word AI means way too much. So you get all these semantic mix-ups, linguistic socialization, things like that. So what would be, I'm still thinking about what my question would be, but what would be the right scale to frame the right words outside of AI? If someone says AI is going to be the savior of, it's way too big. It says nothing. So at what scale do we need to do this? That would be it.
Marcel. Yeah, look, maybe one answer to that, because we throw all of AI on one pile, basically, right? Yeah. But there's a lot of different technologies underlying that, right? So and today we talk a lot about large language models, right? Because that's of course the latest, and I think it solves a lot of things that we couldn't solve before with other types of AIs. And we should also use it for the things that it's good for at the time you're going to use it, because in a year it's much better. But there's also other AI techniques, or not even just technology, which will solve some of that limitations, or which is much, well, we use RAG, right? But there's also, there's AI in imaging, which is a completely different AI than generative AI. So I think I agree with you, you need to go one layer deeper.
So be specific about the technology?
I think that's at least part of the answer, yeah. Not the full answer, but maybe my other panelists have other ideas, but I think it would solve a few things already.
I think that there's a reason why in many of these research proposals and those that get granted, we are working with use cases. Because the scale is indeed, as you said, enormous, but if you look at specific cases, you can really tease out what is going on here. I remember that with the genetics use case that we had, my question constantly was, but what makes it so specific to AI, the questions that you are raising now? Because it was about the heel prick, and everybody was talking about ethical questions that have to do simply with, well, simply, it's complicated enough with the heel prick, but not with the AI technology that could be used in the future. If we don't tease that out, if you're not specific about what is actually the ethical question related to the AI technology that you're using here, then it's a conversation about nothing.
So be specific about the technology, be specific about really the use.
Yes, yes.
I just have to add, no, I just have to add improving AI literacy is vital for these things, because what you mentioned, like if you if you have a reporter who's asking the general public, what do you think about AI? You're absolutely right. That is a hollow term. It is an umbrella term. It says nothing. And therefore, you cannot address the issues. And so what we need is that we need everyone in society to have a basic understanding of what is AI. And if someone can explain what machine learning is with regard to AI, that is, the difference is AI is the concept and machine learning is the way we do AI. A lot of people don't know that. So I think improving AI literacy in all of society is like a prerequisite for these issues. Good question, by the way.
I wanted to link to your suggestion for the future, right? If an AI could have access to a lot of knowledge, there are already very interesting examples of how that can be useful. One is that if you would be able to look in very large patient databases into combinations of symptoms, then if you have a rare combination of symptoms in your room, and you could look up what is a possibility, right? And the other thing is outside this domain, which is already being used, I think, is in pharmacy to look for new components, right? Where you look into the literature, see what's going on. So that was just to add. And the other thing is a different topic, but I always find this interesting that modeling in the general sense has been taking place for a long time already, for decades, right? To try and predict something. Some aspects also here we have the 3D lab, right? That's not AI, but it is modeling, and that also has some uncertainty about it, but we use it, right? And you go through the CE marking and everything, but we use it. And I think the patients don't ask, what was this model about?
Right.
And do you make the right piece for my, and that's also related to what we have changes in the last decades about what we consider AI. Like regression models are now called AI, but we've used them as regression models for a long time. So I agree with Jetse that we should be very specific about what are we actually talking about, and maybe take it more from specific examples than from a very broad discussion. This was not really a question, just some thoughts. Yeah.
Thank you. Then I'll do a proposition. So if you talk about, let's say, machine learning driven probability calculators, try to be specific here, then I would propose that data is much more important than machine learning. What would your reaction be? Mark.
I agree, because I think data, regardless of the exact technology, is always the basis.
Yes, you can?
Yeah, so I don't know let's do this. Who has ever created an AI model? Who's done machine learning in Python? Love it. Me too, by the way. So who had their hand up, and who wants to answer this question? You, and then you can ask a question. How long did it take you to get the data and to clean the data versus to train the model in percentage?
90% to 10.
Yeah. Period.
Data is more important than any machine learning.
You said 90% cleaning up the data, 10%?
Getting the data, cleaning up the data, but also verifying the ethical usage of the data, and then embedding the model.
Good addition.
I again would say, I rest my case. It's clean data.
Well, you had a question.
Yeah, so I spent a lot of time in the US. I actually just came back. And what always strikes me is, how do you as a group then, if you flag something which you think is barely legal, but it's actually used in a grand scheme, how do you deal with that as a group? I'm not going to name drop companies here, but I literally came from San Francisco and I was shocked from two of the biggest companies in the world who do stuff with AI that I think, is there like a board where everybody talks to each other about, well, have we seen this? How do we deal with these ethical questions? Well, we all know they're already being used.
I mean, we won't share this with anyone, but could you please give the example?
Well, there's a big insurance
confidentiality.
No, there's a big insurance company in the world. There's a big insurance company in the world who gets data from medical records from a medical system. No, I said we're not going to do names. But then they make they give an advice on what to medical treat a patient based on the history of their credit data and the medical data. which I think is a bit of a boundary. Like, you know, you're getting into a hospital and then the system says the creditworthiness of this patient together with the medical data of this patient actually grants this kind of treatment, which is covered by this insurance.
I have a follow-up question because it's important. Do you have an example in Europe? Because I don't think you will have an example in Europe.
Those two companies also
in healthcare
operate in Europe if you consider the UK as Europe. Let me put that then.
So
because the legal system.
I don't.
Sorry. So the reason I asked, and I mean, obviously, if you say it's a thing, then it's a thing. The reason I asked is because obviously I do like legislation. The reason we want legislation is that so we can do stuff safely, but there's a trade-off there, right?
Mm-hmm.
So because of the MDR, because of the AI Act will come into fruition later, but also the GDPR, et cetera, et cetera. The chances of that happening in Europe is a lot less. That's one. And two, it's really important, and that is one of the reasons we have an AI program. We want to coordinate what we do with AI in our hospital, is because you need to think about where does the data come from? Is the data biased or not? Is the patient population that the model is trained on, is that comparable to mine? Should I retrain, et cetera, et cetera? So there are a lot of considerations that go into when you talk to a vendor about transparency, et cetera, before you sign a contract and give your patient data. And I think you're absolutely right that there should be a lot more awareness on which questions to ask and what to demand from the supplier.
How would you react to the example just given? Because if I understand correctly, it's a treatment plan according to based on
your insurance policy. The amount you can use on your insurance policy is determined by your financial data and your data from the hospital, which is used widely in the US.
Yeah, but then again, that's already a system that we don't have here because we want to protect people, because in general, laws are there to protect people. In the US, it's to protect you from the state. Here, it's to protect you from maybe big companies. So that's a bit of a difference. So that it's not possible to have an insurance company having access to your financial situation. And there's also another thing that we really uphold, and that is equal access to healthcare. So it can't be based on that. So the starting position is already completely different. And I want to add that there's a reason why the big companies are knocking on the doors of members of parliament in Brussels. It's because they want these kinds of protective measures changed. And I think we should be glad, as you said, I totally agree, well, you already knew that we have these protective laws. And they aren't ideal, they aren't heaven, we're still on earth, so there are some flaws in it. Sometimes also it helps to be a bit slower than those big techies, so that we can uphold those other values, because it's not only about progress, it's also about progress for human beings, but maybe not only for human beings, but for the entire earth. And how are we going to do that? And sometimes you need to step back and think and reflect. And that's what some of those regulations make us do.
2 minutes for 2 questions.
Well, it's not a question, most a remark based on the example from the United States. It's also a matter of viewpoint, I guess, because here we have universal healthcare. We think this is abysmal, but the United States is more a capitalistic healthcare system. And if you are poor and you don't have healthcare, well, is it that bad that the system will provide you with affordable options that fit into your plan, instead of saying, oh, you can get like a kidney transplant, it will cost you $500,000. So it's also based on society, I guess. In the United States, they've made their choices and say this is allowed and legal. And here we say we don't want it and we want to have universal healthcare. But is it that bad? I don't know. It's a different mindset, I guess.
This is not a question about AI. This is a question about social justice. So we should
cultural differences also, which
should
reflect in legislation. So the Chinese government records their inhabitants, and if you ask the Chinese, well, you know, I'll just leave it if they're honest or not, but they don't mind. There's a cultural difference in what we see as good and bad.
Minus 30 seconds.
Yep.
Yes, I wanted to ask a question because what you said is that the basic understanding of AI is a prerequisite for using and implementing it into society. How viable is that? Because maybe I don't have that much of an expectation of public knowledge and trainability. But
Sure. I'm an optimist in this, but I think, I mean, it'll take time, but we have to put this into our schools. And I think, we have math classes, we have English, there should be some form of schooling in AI. And that is what we do in our hospital. We're also talking with the medical students or the geneeskundeopleiding, right? So to put that into the curriculum. But I mean, this will all go into, hopefully, into elementary school where we get like a broader understanding in society of what AI is. But it will take time.
Thank you so much. We have food for a lot of thought and another few hours of discussion. Thank you so much to all.
Thank you all.
Thank you for the great discussion. And before you sit down, I have for each of you as an appreciation for all the and while I'm doing this, you can give an applause, for instance. Dankjewel. And then there's one for you, Job, as well. You're going to get it in a minute. So I want to do a quick wrap up. So I hope you've enjoyed the program. I think it's been a dynamic discussion and many topics were addressed. And we've also reflected on future topics to be discussed and the way we need to do it. But what I really liked about the discussion as well is the thing about, is it a paradigm shift, yes or no? And recent publications that were highlighted already, the 7 minutes going to 15 seconds, that opens up a paradigm shift. In light of this project, we are looking at how intensive our doctors are using the electronic health records. And what you can see is at night or in the evening, a lot of logging in is happening. A lot of preparations for the clinics for tomorrow is happening. And this type of technology can really open up, our doctors having family time again, or maybe going read a book, or have more sleep, or do exercise. So I think there's a huge opportunity opening up here. And I would really like to invite you to continue reflecting upon this during the drinks. So what I pre-discussed, so it would be really good if the speakers together go to the personeelsrestaurant. So we go 2 floors down, and there you will see the personeelsrestaurant where we have drinks, we have some snacks, but also a lot of food for thought that was delivered during the meeting. So thank you for attending. I really look forward to seeing you again in future meetings of DASH, and please join us for the conversation.